Hi everyone, welcome to Pathology channel. As I told you before, we are here to begin with a slide discussion for exam going postgraduate. So it's time to sharpen your mind because we are about to unlock the secret hiding under the microscope. One system at a time, slide by slide, system by system. Let's decode the clues and solve the pathology puzzle like a pros. Where every slide tells you the story and we are here to crack it together. So I have provided the history with 43-year-old female breast lump and the images are provided, and I got a few comments also regarding the answer. So these are the images which is given actually. So we'll see how it goes. So first we'll discuss about according to the WHO Blue Book recent edition, we have to know what are the benign precursors of the breast lesion according to WHO Blue Book. So first moving on to the usual ductal hypoplasia, which arises from the terminal ductal lobular unit, and it may associated with other lesions like intraductal papilloma, fibroadenoma, radial scars, complex sclerosing lesion, and adenomas. So they don't usually present as a mass. It's an incidental finding, and the pathogenesis is more towards due to the activation of PA3K AKT mTOR pathway. In histology, you can see there will be a cohesive proliferation of epithelial cells, half-facade orientation will be there, and there will be a presence of secondary luminar fenestration, which is a characteristics for this usual ductal hypoplasia. And the nucleus may be variably sized, along with the grooves and intranuclear pseudo-inclusion can be present. So if you see IHC wise, the ER will be variably positive and the cytokeratins will be positive. So what is the cancer risk progression for this particular case? There is 1.5 to two-fold rise which can progress to breast carcinoma. So these are all the important key points which you have to know. Usual ductal hypoplasia, at least you have to remember the histology points and how will be the IHC and what is the cancer risk fold. So next moving on to the atypical ductal hypoplasia. Okay, so this is also a benign epithelial proliferation lesion along with the cytological and architectural features which are similar to that of a low-grade DCIS, but it has a lesser degree of terminal ductal lobular unit involvement. Okay, they are also diagnosed during the routine screening mammogram as an incidental finding associated with microcalcification. So here what is the pathogenesis is mainly the loss of heterozygosity in the atypical ductal hypoplasia and also the low-grade DCIS. So these are related as a clonal process. So it's quite related to DCIS and progression towards the cancer. So histologically, they are arranged like a irregular with a distinct, indistinct borders, very rounded, punched out lumina, monotonous cells with round nuclei. If you see architectural features, they have a rigid bridges, uniform thickness, and bulbous micropapillations will be seen, and with a narrow basis and broad tips. So the cribriform pattern can be also observed. According to the study of Page et al., less than 2 involved spaces are classified as ADH, that is your atypical ductal hypoplasia. And according to Tavazzoli and Norris, less than or equal to 2 mm is classified as ADH, and if it is more than 2 mm, it's classified as DCIS. So IHC wise, ER will show diffuse positive and cytokeratin will show negative. What is the cancer risk progression? 3 to 5-fold rise of cancer risk progression. Next, moving on to the columnar cell lesion, flat cell atypia. So here, this is a clonal alterations of TDLU where it will be presenting like an enlarged variable dilated acini lined by the columnar epithelial cells. So the flat cell epithelial atypia will have a low-grade monomorphic cytological atypia. So they are also detected by incidental finding as a screening in mammogram, but there will be a group of amorphous calcification which will be present here. And the main pathogenesis is mainly due to 16q deletion. So if you see histologically, there will be enlarged and dilated acini lined by the columnar epithelial cells, and they have atypical cytoplasmic snouts. These nuclei will be round, ovoid, regularly oriented, perpendicular to the basement membrane, and they do have luminal secretion, microcalcification, etc. So if there is 1 to 2 cell layer changes, especially, you will call it as a columnar cell change. If that is more than 2 cell layer thick, you will call it as columnar cell hypoplasia. Note the difference here. IHC wise, ER will be diffusely positive and cytokeratins will be negative. And what is the cancer risk progression? 1.5-fold risk progression. So this is the final answer. The first image shows you the usual ductal hypoplasia. According to that, I told you, there will be a slit-like fenestration which is very characteristic for this. You can see there is a basal cell layer of myoepithelial cells along with a punched out fenestration at the periphery. So this is characteristic for usual ductal hypoplasia, and atypical ductal hypoplasia, here you can see associated with a microcalcification, and there is a little kind of cribriform pattern is also observed in the second image. And when you come to third image, it's a columnar cell lesion where you can see these cells are lined by the columnar with the ovoid nucleus. You can appreciate there, and along with a grouped amorphous calcification, which you can see here also. So this is the three differential thing which you can observe on incidental finding along associated with your carcinoma and also as a benign lesion. Okay, so keep in mind all the important characteristic points and try to focus on the slide and detect the UDH, ADH and columnar cell lesion like that. Okay, so we'll see in the next class with some other new interesting cases. Until then, stay tuned with Patho Bye bye.